everyone. Welcome you all back to the third season of Foundation course in Palliative Care. So, hope everyone is safe and keeping well. And many of our participants are yet to join. It's 3 and let's start the session. So, for the last 2 days, we were discussing about communication, how it plays a very vital role in a palliative care setting, and what is the importance of breaking bad news to the patient and their families. So today we are going to see a very different topic, which is very vital and very crucial for the existence of and the sustainability of palliative care. So which is the community. So without community, the effective functioning of palliative care setting is not going to work proper. So today we are going to deal with the community and palliative care, the scope and advantages of community volunteers in palliative care, and the different initiatives which can be taken by the community volunteers. So for that, we have a wonderful faculty here, Mr. Binod Hariharan, who is a trustee of Pallium India and also an engineer by profession. He is one of the people who were involved with palliative care from the initial days of palliative care in Kerala. And he is currently heading three organizations. He is the director of Astrovision Future Tech, director of Malayogam Limited, and director of Wedvisor People Connect Private Limited. So we are very happy to meet you, sir. And sir, please.
Thank you for that wonderful introduction. Am I audible? Am I audible? Hello?
Yes, sir.
Okay, thank you. So let me share this presentation with you. Share screen. Yes. Is it visible?
Yes, sir, it is.
Okay, so good afternoon, everyone. I understand most of you are from within the country, so at least the time zone is the same. And I also understand that all of you who have joined this session, we come from different backgrounds, mostly from the healthcare setting, and people who have been working in the healthcare sector. And some of you have some background in palliative care already, in the sense you are either working in a palliative care unit or maybe even working as a health worker and aware of some of the palliative care basics. So today we are going to look at how the community can actively play a role in ensuring palliative care delivery to the society. So I would like to have this as a more of a discussion. So feel free to interrupt me whenever you feel like. You can also put in your queries on the chat box. We'll pick it up, and someone should just keep a tag on, the comments coming on the chat box, and just remind me in case I miss out any. So shall we? Okay. So essentially, we'll be looking into the role of community in palliative care, volunteering, and we'll also have a look at the Kerala model, as they call it, in palliative care, and the relevance of collaboration, the community-based resources that are available, and the need for collaboration. So this is something which I believe all of you have already gone through this. It's it's the definition of palliative care as we know it, which is laid out by the WHO. So it talks about palliative care as a kind of care which is provided to persons with life-limiting illnesses, and it's from the point of diagnosis till the death, and beyond that into bereavement care for the family. And so it's not just care for the patient, but it's also care for the family of the patient. Now, obviously, this is a tall order. I mean, if you look at the current healthcare system, which involves the hospitals and the government infrastructure that provides healthcare, you will find that mostly it is healthcare providers who are primarily providing the care, doctors, nurses, and social workers, of course, and of course paramedical and all those set of people. Now, here in palliative care, what happens is you are looking at multitude of problems, which means that all these people who are working towards providing care for the patient and the family, they need to actually come together, irrespective of their specialties, so that you get the ideal result. And more so when you're talking about continuity of care across multiple healthcare settings. And as we are all aware, most often a patient comes into palliative care or under the palliative care umbrella when the person has gone through a lot of suffering, not just the patient and the family, and then you reach a point often when the hospital says nothing more can be done, and so then you take care of the patient at home. So you're looking at providing palliative care right from the hospital onto the home, and even if it is required in the hospice, sometimes it's also a long-term care. So look at the challenge that we're talking about. With the current level of infrastructure available in the country, how would that be possible? Would the government machinery be able to do it? And of course, if you just spend a few minutes, you will understand that it is simply not practical in a country like ours. So let me just start off with a scenario. I want you to imagine yourself in this situation, and then come out with your thoughts on that. How you would look at the situation and how you would react. Now, you have a neighbor, a lady, who is screaming all through the night. So you can hear the scream. You make a preliminary inquiry and ask probably the other neighbors or even your family members, and you understand that the person is a cancer patient. You know that there is a government hospital nearby, and there is a multi-specialty hospital which is slightly away. And there are also doctors and nurses whom you know in the vicinity, but you're not aware of any palliative care facility which is providing that kind of care. So imagine that you are in that situation. You have this neighbor who is screaming all through the night. You understand that the person is a cancer patient. There are hospitals nearby, and you also know some of the doctors and nurses. Now, what would you do? How would you consider this situation, and what would be your reaction to it? It's open to all. Anyone can feel free to step in and contribute. What would you do? Let's see. Okay. Is she living alone, family, Okay, good question. So, if you're not sure. See, this is the information that you have. You don't know much about the family or whether she's staying alone. You don't know much about that person. You know that that person is screaming, and then one could find out about what pain meds she has been on. Sindhu, thank you, Sindhu. Yeah, you could find out. What else? Anything else? So call her doctor. Plan for home-based palliative care if doctors are ready to serve. Okay. Thank you, Mohan Kumar. Thank you, Sindhu. So anything else?
Mr. Biju, this is Mudre from Mysore. May I come in?
Yes, sure. Of course.
Okay. I feel the first step would be to go and knock the door and find out how the pain can be regulated. If any medicine is available already, if she's on some medication, that can be done at home if the prescription is there already. Some kind of medication can be given, and probably some symptomatic relief if it is given, then we can think of immediately shifting her to the hospital. Probably they may be requiring a vehicle to be taken to the hospital, and that should be the first step. So go and inquire what kind of assistance you can provide. So then you can see how things can happen later. Definitely it will be a sequential thing, going to the hospital, finding out whether palliative care is there or not, what kind of treatment she is on, and what is to be given, what treatment has to be given. And that's the way it has to be. Maybe they are seeking help from somebody, not necessarily a doctor. Maybe we are able to help out without even a doctor or a nurse. It could be possible. It could be a simple maybe a circumstance could be that she must have fallen from from the bed. It's possible. So we can just put it back on the bed and see that what best can be done. I mean, first step has to be good. Go there, knock the door, take that courage to go and knock the door and talk to them. Thank you.
Yes, thank you. Sorry, I missed your name.
I'm Ramakrishna from Mysore.
Thank you, Ramakrishna. That was wonderful. So I don't have to, I don't think I have to take this session anymore because you already know what is to be done. Absolutely, 100%. You're spot on. I believe the first step is to reach out. Knock on the door, as Ramakrishna said. Find out what is happening. And like you said, it need not necessarily be because of pain, because of cancer. Okay, you know that she's in pain, she's screaming, but pain could be due to many other reasons. Like you mentioned, she must have fallen off her bed. That could be the reason. Or maybe her husband is torturing her. We don't know. So there could be so many possibilities which we are not aware about. And like Ramakrishna said, you have to have the courage to step outside, knock on the door, and then try to find out what exactly is this person going through. And also try to understand that those questions which were asked earlier, like Sindhu, is she living alone? Is there a family who is supporting her, which is supporting her? So these are the things which we need to know, which if we are not aware of, we need to go out there and find out for ourselves. And then probably we'll be in a better position to even consider what kind of support that person or the family would require. So yes, Pallab Bhattacharya says to ask for immediate reason for pain and assess the method. Yes, exactly. So if we go and ask what is the reason for that pain, or why she's crying. Maybe you'll have a new story come out. And then, of course, you can decide whether it has to be, you need to take that person to a doctor. Sometimes you don't have to take that person to a doctor. Maybe a phone call to a doctor and suggestions from that doctor or a nurse would be sufficient. It depends on what is the state, what is the condition, and what is that the person and the family requires. So we said that we require an interdisciplinary approach if we need to provide the kind of care that is required for a patient like this. Now, who are the team members? Again, I would request all of you to step in and put in your comment. Whoever you feel are the right people to be part of this team, which is supposed to provide care to this patient in need. Anyone? Who are the possible team members who should come together to provide the care that this person, this patient, and the family should get?
Doctor,
sorry.
Hello. This is Mohan, sir. Yes, sir. Doctors, nurse.
Doctor, nurse, yes. Who else? Sindhu says, whoever feels to. I don't know who is Moto G says volunteers. Okay. Again, Vallabh says volunteers. Who else? So volunteers, doctors, nurses.
Ambulance driver.
Spiritual
Excellent.
leaders.
Thank you. Spiritual leaders. If 12 a.m. then, sorry, I didn't get that.
Sorry. I'm having difficulty typing. I just meant in this scenario, we are her neighbors, and once we find out who she's connected with, but immediately it could be any one of us living around her, I think, as Dr. Mudre and you both said.
Okay. So yeah, you're right. So it could be pharmacists, social workers, music therapists, bereavement counselors. We can think of all these people, the therapists, the physiotherapists. But then these are the set of people we often tend to forget, including the driver. I think it was Dr. Ajay who mentioned this. So volunteers, family, and other caregivers. Let us not forget the role of the family. We often tend to forget that irrespective of where you are, whether you are in a hospital or at home, your primary care providers is your immediate family members. And unless you consider them as part of this team, we will not be able to provide the right kind of care. So yes, if you put all these things together, so as Cindy said, whoever feels to, your neighbors, us, all of us together. And I think we are missing one more person here. And who is that?
The patient. The patient himself is a part of the team.
Absolutely. Who is that, Ramakrishna?
Yeah, Ramakrishna.
Yeah. Thank you. Yes, you're spot on. And let us not forget the patient's role, because if the patient is not with us as one of the team members, we'll find it very difficult to provide the care as well. So thank you very much. So in essence, what we're talking about is anyone who can contribute to improving the quality of life of the patient and family. So whose business is it? I think it's more or less clear now. we say palliative care is everyone's business. Now, when I say business, it's not like, you don't have to give that monetary connotation to it. It's about everyone needs to be involved in this. We are all in it together. So once we understand this, our outlook is going to change. The kind of care that we can provide these people is going to change. The whole scenario is changing now. So the title is not proper. Forget about it. It's actually the healthcare system that we see it now. So we know that at the macro level, we have all these hospitals, medical colleges, the government infrastructure, primary healthcare facility, tertiary, whatever. All those things are there at the macro level. And as we just mentioned, at the micro level, we are clear what it is, right? It's the family, your immediate family, or rather our immediate family members. At the macro level, it is always the family which is providing the health care. Now, there is a level in between, which we call the meso level. In between the macro and the micro level is the meso level. Now, this is what makes things very interesting. What is this meso level? Now, it's the community, what we're talking about. The community which includes you and I, all of us. And therein lies what we call the social capital. I don't need to explain what capital is. If you need to provide any kind of service, you obviously require capital. Now, capital would be human resource, would be one type of capital that you require. You would require machinery sometimes. You need, like for example, for transportation, you need a vehicle. You need capital for if you are running a inpatient facility, you need funds to set it up. So all this is capital that you require to set up something which can provide the kind of care that we're talking about. Now, what is social capital? The social capital is that capital which is lying there, which is available but not being utilized. Often we find that most of the challenges that we find in a country like ours, especially, those things are solvable. You have the solution out there. It's in the society. It's a social capital, what we're talking about, and it's more or less like a treasure box. It's a treasure box which has got the solution for all your problems, whatever challenges you're going to face. But then, unfortunately, it is locked and the key is not with you. Now, it's about finding that key. Once you have the key and you can unlock this treasure box, most of the challenges disappear automatically. I can give you quite a few examples here. Now, the situation that we described earlier with the neighbor in pain, and we discussed about how we should try to provide the care, going out there, finding out what is actually happening and all that. That was not a fictitious situation. It actually happened. It was a real story. It actually happened way back in 1992 in a place called Calicut, which is on the northern part of Kerala. And this person was actually not a healthcare provider. He was just a lay person who didn't even have a graduation or a degree. And it was this screaming which was unacceptable to him. and he ventured out and tried to find a solution for this person in pain. And what happened then was that, this person went and talked to a doctor whom you knew, and then that doctor led him to another doctor whom he knew about pain care, pain relief, someone who could help this patient. And all these people came together and actually formed the first palliative care society in Calicut, which is called the Pain and Palliative Care Society. Even today, it's in existence. And now, when it progressed, there are so many other stories which are connected. Like, for example, there was a situation in the government medical college. Now, this Pain and Palliative Care Society was also part of functioning within the medical college premises. So, in the medical college, you know how it is in the general wards. The kind of situation that you see, which is nothing short of chaos, I would say. You have screaming, shouting, and you know how the patients and the family, the suffering that you see. And in that situation, there was the doctors wanted to provide some care to a patient in the general ward, which involves a procedure which could not be done in the open. They needed some privacy. So obviously, there was this discussion on how to find a room or a procedure room, as we call it, which is not available. And this same person steps in and he tells the doctor, you carry on with your preparation. Don't worry about the privacy and the room. I'll arrange for it. You know what he did? He went outside. He went and talked to a textile shop owner, convinced him about the requirement of the patient, the suffering that the patient is going through, and the kind of help that the doctors need to provide, and then asked him for curtain cloth, which this shop owner readily agreed to. He gave him free cloth. He took the same thing to a nearby tailor and again narrated the same story, the requirement, the patient in pain, and all those things. And then this tailor agreed to stitch this cloth into a curtain and provide it. All this happened over a period of few hours. And by the time the doctor was ready, this guy had a screen around the patient in the general ward, and you had the procedure room ready for the doctor to do the procedure. Now, this is what social capital can actually help you achieve. So it's not about finding money for everything. It's about getting people together, getting people who are willing to contribute, support, be involved, help someone. That is where the challenge is. Finding out these people and remember the key. If you can find the key, you'll be able to unlock these doors, unlock this treasure box. So we'll move on. So who is a volunteer? This is the definition that you'll find in any dictionary, but then let us not get bogged down with this definition. We'll just hear the story of Mr. K.N. Nair. Now, a gentleman, he is 65 years old now. He joined the army at the age of 17, retired in 92, and in 2000, his wife was started to have, or rather, she was having pain and other problems. And then he took her to almost all the major hospitals in the city. He took her to an oncologist even, and they went through all the other, the typical scans and everything else. And none of them really diagnosed the problem. And it was only in 2002 when she was actually diagnosed with stage 3 cancer. By the time it was diagnosed, it was already a bit too late. It was stage 3. And then she passed away in 2004. So for almost 4 years, it was suffering for her and for Mr. Nair, who was the primary caregiver. And then she dies in 2004 now. Again, I want you to put yourself in Mr. Nair's position. Assume that you are in that situation, in his shoes. Let me know how you would feel. What would be the thoughts that go through your mind? And I also want you to think about what would be your possible course of action. Now, you have lost your loved one. Okay, it could be your husband or wife, depending on your gender. And you have gone through this long process of diagnosis and suffering and all those things, and you lose the partner. And then what goes on through your mind? What would be your possible course of action? Next step, how would you react to the situation? So again, the floor is open. Feel free to step in and say what you, share what you feel, or you could use the chat box as well. Anyone? I would like to help other people suffering from serious disease. So that is what Rita feels. If she was in K. Nair's position, she would think this way. Okay. Thank you, Preeta. Good. Anyone else? So I just want you to also share what you would be feeling. What are the thoughts that would cross your mind? How would you feel about that situation? Your emotional state at that point of time. In the meantime, let me get a gulp of water as well. Sorry.
Sir, can I add something?
Yes. Go ahead.
I would
Who is
definitely
this
have.
speaking?
This is Gayatri from Palliative, India, sir.
Okay, Gayatri, go ahead.
I would definitely have a kind of helplessness because I was unable to realize my wife's disease, or my husband or my partner's, or whoever it is. I was unable to realize his or her condition. So I would definitely think what kind of treatments or what kind of support would be there if patients with same conditions suffer. So I will definitely have a kind of helplessness because I was totally unaware about this, her disease, her pain. I couldn't do anything for her. So that thought would definitely be there.
Yes, Gayatri, thank you. Okay, so Parag says, initially helplessness, worried, and finding out a way. Yes. So helplessness, what else? helplessness, worried?
This is Mohan, sir.
Frustration? Yes, Mohan. Yes.
As she was in a stage 3 cancer, most of the time we think it is a last stage. Maybe we only pray for her dignity death, not for saving her.
Okay. So you feel we should look at that possibility also. Is that it? Or
Yeah, sir.
Sorry. What I understand is you feel that we should not ignore the possibility of cure. We should give that also a try. It should not be just treating the pain and other symptoms. Is that what you're trying to say?
Yes, sir. Yes, sir.
Okay. Yes. Okay. So there is still that possibility of a cure. Yes.
Yeah, Mr. Binod, this
Yes.
is Ramakrishna from Mysore.
Yes. Go ahead.
Yeah, there is every possibility that when this kind of event happens in life, there could be a sense of guilt. That how is that I did not notice this in my spouse? Why it missed my attention? Why I did not take her to the doctor for some preliminary investigations or on the annual medical checkup? Why I did not do it? This is the kind of thoughts that will be coming initially, and how to come over this. Then you will start this line of treatment and everything, all those things. But that sense of guilt always prevails. I should have taken some kind of action earlier. I could have saved my spouse. Probably this is the kind of this, when it happens, he'll be requiring a lot of help from the community also, from the extended family or friends, to see that he is able to come out of that sense of guilt and start working again. Thank you, Mr. Vinod.
Absolutely, yes. Thank you very much, Rameshna. Yes, I think all of you are right. It's that self-hatred. Palliative says, unable to accept reality. Kuldeep Kaur says, Srikala says, devastated, try to all possible things with an ease out her misery at least some bit. And the guilt, it's a very interesting thing that Ramakrishna pointed out. Now, can you also guess what the doctor would have told him when the diagnosis actually happened? So while in once the diagnosis was made, can you imagine what the doctor would have told him in 2002? Now she is diagnosed with the 3rd stage, and yeah, you already, like Ramesh said, you already have that guilt. You are finding it difficult to accept the reality, the self-hatred, frustration, helplessness. You are sitting in front of the doctor, and can you imagine what the doctor would have told him? This is something which you often hear from many healthcare professionals, including doctors.
Maybe this is a third stage cancer. There is no definite line of treatment or saving point. Maybe you can manage only, I think so.
Okay, so again, sorry, I didn't get your name. Could you?
Mohan Kumar.
Mohan Kumar. Okay, thanks, Mohan. Yes. Typically, it would be like, matter of fact, this is a situation, there's a condition of the patient now, and chances are, like, it's the 3rd stage, you can't expect much, and a typical this thing would be nothing more can be done. And on top of that, you typically hear another question. Why didn't you bring her here earlier? Or if you had brought her here earlier, maybe we could have done something more. Now, this is something which is not unusual, and most of us would have experienced this firsthand also. Now, you understand that you're already going through that guilt. On top of that, this is, okay, you have the self-inflicted guilt, but this is guilt being added on to your existing thing by a third person. Now, all these things are there. You are in a terrible, terrible situation. Now, how would you react? What would be your course of action? Like, you have all these things in your mind. And what would you do at that point? What would be the first thing that you consider doing?
Yeah, Mr. Binod, the normal reaction would be to see that we will fight it out, sir. We will see that our spouse will be all right. You kindly suggest the best treatment available. We will provide all the resources. I want to see that my spouse alive. This could be the demand.
Okay, so let me correct myself. So I was thinking of the situation where she's already dead, in 2004.
Okay.
Once she passes away, then what would be your next step? What would you do? Sorry, I didn't clarify myself earlier.
Yeah. Now, with the sense of guilt, that that inactiveness will definitely creep in. You don't feel interested to do anything, and you'll be getting aloof, getting isolated from the society, and you do not try to interact with people. But to cope with, for how long this can be done, if a man is really self-goaded person or motivated person, he will start doing something to come over that guilt or come over that grief. And as we see here, Mr. Nair, he has completely harnessed his energies to see that he is able to come out of the guilt to providing service to the people. I mean, that's the best course of action he has. As a matter of choice, he has taken that. And many of us, we definitely feel helpless and see for ourselves, we'll just why should we bother about ourselves? I have lost my spouse already. Let me be with me. Yes. I need not bother about others. Let me spend my time, whatever that's balanced time available in my life, let me spend. So when that sort of things happens, unfortunately, a resource is being wasted. Instead, probably Mr. Nair has taken the right decision to see that he's alive and he's kicking yet, and he's still helping people who are in the similar situation as his spouse was. That's a wonderful gesture on his part.
So I never mentioned that he is. Thank you very much. But do you know this person by any chance?
No, the photograph shows that he's a volunteer. He's standing near a van. Obviously, he should be going to the field and meeting in the community. He should be meeting patients and talking to them and filling them with confidence.
Okay, you're a very keen observer. I must give it to you. So there is this possibility of staying aloof, keeping away from the society. You don't want to meet anyone, do anything. Let me just be with myself. Maybe you think that, okay, let me enjoy the rest of my life. Meena says need counseling. Of course, anyone going through that stage counseling would be helpful for everyone. But apart from that, if I were in a situation, my first reaction would be, no, I went to all these doctors many times. I went to all these hospitals. They never diagnosed this properly. And then I am left to suffer because of their negligence. So why should I be the person suffering? They have to pay for it. they need to, pay for the mistakes they did. And that is a typical reaction that you find often. And that is what leads people to walking into a hospital and, what happens then, a destructive episode, or you could just walk into the doctor's cabin and then hit him. Now, these are things which happen in our country. It's not like, this is a very rare situation or anything of that, but because, you are in such a situation where you don't even have control of your emotions. But then, as many of you rightly mentioned here, there are some who are able to get over it, who are able to harness this, and also take this decision not to just stay aloof or keep away or not to react, but then the choice of getting more involved in other people's lives, other people's situations, so that something similar doesn't happen to them. Or if someone is going through that kind of a suffering, let me do my bit. Let me also see what I can do to help him or her. And that would be more fulfilling for me. Now, this is a choice. This is a very personal choice. And people take different decisions. It's an individual choice. But then, as you rightly mentioned, Mr. Ramesh, in this case, K. Nair chose that. He decided what happened to me, what happened to my wife, that should not happen to others, other family members. Let me do my bit. Let me use the rest of my life, the time available, to ensure that someone else doesn't go through this kind of suffering. Now, why did I mention this story? So we are talking about volunteers. Now, this is where a volunteer is born. And most often than not, we should understand that most of the volunteers go through some kind of a personal experience. It might be within their family. In K. Nair's case, it was his wife. It need not necessarily be within the family. It could be your neighbor, like we discussed earlier. It could be a distant relative, or in some cases, it could be even patients in a hospital, doctors. There are many doctors who actually go through this, see this kind of suffering, and then decide, no, I should do something to make sure that others do not keep suffering like this. Now, whatever may be the background, these experiences are often what lead someone to take up volunteering. And we should know, we should understand that there is this suffering and the experience that that person comes with. And it's important to understand or know the story behind the volunteers, behind a volunteer. Now, let us move on to how that person can help a volunteer like K. Nair. What is his role in palliative care? Of course, patient care. If the proper training is provided to that person, a volunteer can, of course, get involved in patient care. But then apart from patient care, what else? You can all, there is nothing wrong or right here. Feel free to step in and share your thoughts. What can they do in palliative care? We are very clear that
community facilitator.
Community facilitator. Could you just explain that or elaborate on that? What kind of facilitation?
Uh,
And your name also. Sorry.
my name is Sunita, sir.
Okay, Sunita, go ahead. What kind
A
of
community facilitator, like searching the patients in the community, helping them with the proper care and referring them to the medical or the palliative care.
Okay. Okay. So
the patients who cannot travel to the hospital, who are bedridden can help them, providing healthcare facility
Yes.
to the patients.
Yes. So
So Mohan
it's
Kumar.
connecting. Yeah. Please go ahead, Mohan. Yes.
Yeah, maybe the volunteer's role may be to guide them for social entitlements.
Okay. Excellent. Yes. Yes. So if you are eligible for what do you call a ration change in your ration card status to below poverty line, or you can apply to some government institution or a department to get additional what do you call it, support, financial support or other kind of things. Maybe healthcare. There are specific entities who are providing that kind of care. There are specialized institutions. Maybe apply, put in an application and get those kind of things. Yes, Mohan Kumar, you're absolutely right. So facilitating that again, like Sangeeta was mentioning, it's about facilitating. It's about educating the community. Parag says educating the community, create awareness. I absolutely even letting them know that okay, there are alternate ways of providing care, or there are other areas where we could look at getting more support. When the doctor or the hospital says nothing more can be done, there is still something that can be done. So that awareness, educating the community to go out there and seek for palliative care, that is absolutely myths and facts and direction. So so yeah, depending on your background, so I would say sky is the limit. So someone said earlier, transportation, a driver can step in. In fact, there is a team of auto rickshaw drivers in Trivandrum who help Pallium India, or rather help patients, with transportation. They bring them over to us, or in case they need to be transported to the hospital, the medical college, they take care of that, and they'll do that voluntarily without asking for payment. So that is at one end. You have doctors who are willing to volunteer at the other end. So all these things are possible. The sky is the limit, I would say. So advocacy is, again, like you mentioned, someone mentioned awareness, creating the awareness, and of course fundraising also. And most of these things, what you're trying to do, it may involve a requirement of money, which also they can provide. They can help in clerical office work, but then that is not to say that okay, they can only do those kind of things. No, it depends on the person's background. Like for me, my background is I come with an engineering background, so I may not be able to go out there and then directly provide wound care for a patient, but then I can always try to identify some what you call technology, or some maybe an engineering solution which can solve the patient transportation problem, maybe help him sit up straight, maybe help with the better posture on the bed. Now, it depends on what I can contribute, what is my core strength area. Like for example, there are people who have an accounting background who might be willing to step in and help with the what do you call accounts part of it. So anyone with whatever background, they will still have a role to play in palliative care. So it's about identifying these areas where it can contribute, and also earmarking specific dates and time of the day. So time of the day, because see, as you know, any care for that matter, it requires three things to come together. In between, Kuldeep Kaur says, going along with the family during, absolutely, sometimes it helps a lot. You just go spend some time with the patient's family. It's a great support to them. You just You don't have to even speak a word. Just being there, listening to them, that helps. Yes. But then coming back to what we're discussing, it is about three things coming together to provide any kind of care, for that matter. Can someone say what are the three things which need to come together? If you are to provide care, effective care, there are three things which need to come together.
Is
What all
that
do you need?
physical,
Physical. Okay.
psychosocial and spiritual?
Psychosocial,
Psychological.
spiritual. Okay.
Psychological.
Okay. And who is this?
Sunita,
Sangeeta, is it? Sangeeta. Okay. Thank you, Sangeeta. Anything else?
Bereavement support.
Sorry?
Bereavement support.
Okay. So I think I need to make myself clear once again. There are three components which need to come together to provide any kind of care. It may not be even palliative care, any kind of care. Provide, if you want to provide some empathy, yes. Empathy is, yeah, body, soul, spirit, almost there, absolutely. Kuldeep called is almost there. Basically, they say it is the head, the heart, and the hand. The head, the heart, and the hands. And these three things represent three different. It's actually not the head and physically the heart. The head is knowledge. You should know what the requirement is, what the support you need to provide, what to say, what not to say, what to do, what not to do. That is knowledge. That is important. The heart needs no explanation. It is more about, yes, compassion, empathy, your attitude. So that is the heart. And the hand, it's the skills that we're talking about. You need to have the skills. So it's not just enough that you have the knowledge and the heart. Like, for example, you have a patient who needs your care. You know what care is required. You want to, but then you are physically unable to. Now, there is a limitation there. You may not be able to go beyond the point and provide the care that you feel the patient should get. You may not have the time. You may be preoccupied with your own problems. We are all human beings. We deal with 100 different issues every single day, right? So we probably have problems at home which we need to sort out. So we don't have the time. So there are things like, it's not just enough that you have the heart to do it. You also need the knowledge as well as the capability to do it. You need those resources as well. So the knowledge, the attitude, and the skills, these three things have to come together. And that, again, the time is a very important factor. If you don't have the time, whatever you want to do, you'll not be able to provide that kind of care. Now, let us briefly look at the Kerala model of palliative care. It's highly talked about. Now, why the Kerala model? Now, it's not that palliative care originated from Kerala. No. Palliative care was already very popular in most of the Western countries, even in the 80s. And there were hospitals, hospices, especially in places like UK and the more developed world, US, most of Europe, and all those places. Now, until that point, until 1992, when the first palliative care, I wouldn't say the first palliative care service provider, but then as we know it now, the new model came into existence in Calicut. it was imagined that palliative care was only applicable for the developed world. There was no model for palliative care delivery in the developing world, which is obviously a bigger challenge in the sense you have severe limitations with government infrastructure, the financial, the backup, the number of hospitals, the number of healthcare providers. So all these are challenges when it comes to a developing country like ours. So for a country like India, it was not considered possible to provide palliative care. Now that is what changed in '92, and that is what we now know as the Kerala model of palliative care. Now, it's good to understand what is that model, what actually is the difference. But then it does not necessarily mean that whatever happened in Kerala, whatever is happening in Kerala, it can be directly applied to another setting, like another country or another state, as it is. We can understand what is happening, what has been happening, and what is currently happening in Kerala, just to understand the model and maybe adapt that. Adopt some of the things which can be applied to your setting. I understand that you come from different parts of the country, and each state in India is more like a country. The culture is different, the language is different, people are different, everything is different about each of our states. But then, of course, there is one thing that is common, because it's all about human beings and human suffering. That is the common thread. And we need to find new models. But then it is good to understand what is the Kerala model. The primary thing about the Kerala model is that it is community-based. Like we discussed earlier, this is where the community actually started getting involved in healthcare for the first time, probably, in the country. Now, and that changed everything. Now, just like we discussed earlier, most of the challenges that were seen as major hurdles in providing healthcare or palliative care, those things disappeared when the community got involved, when the society decided that it is our business. We need to get involved. We need to step in and provide the care which the people need. It's not enough that we depend on the government and look to the government and say that it's your business. It is your healthcare is the government's primary one of the primary, what do you call it? Now, things that the government should be doing. No. So now there are a lot more NGOs and CBOs. NGOs stand for non-government organizations like Palliative India, for example. CBOs, community-based organizations, like even small groups, a church group, or what is popularly known in Kerala as what is it called? Small clubs, sports clubs. There are literary clubs. There are residents associations. All these are community-based organizations, if you put it there. And now we have palliative care integrated into the healthcare system, where we also have the primary health centers and the community health center. Yes, Lions Club is an example. Now, all these things are happening today. Now, all these things may not be replicatable. We may not be able to do the same thing in another part of the country. Maybe not. But then some of these things can really work. So it's about understanding the model. And what is special is, it's about a multitude of people, organizations coming together along with the government system. The public healthcare system also is there, and working together. At least that is the whole idea behind this model. But then, have we reached that ultimate level of, have we achieved that perfection in that model? No, definitely not. It's still a long way to go. even in Kerala, we can't say that we have reached that level of perfection. No, we still have challenges, and it's even more so when you look at other parts of the country. Okay, so what we try to do in Palliative India, again, an extension of the Kerala model. Now, if we were to reach out to all the patients in Trivandrum who need our support, maybe we'd be able to reach out to a few hundred, or maybe even a few thousand at best. But then, does that meet the requirement of the community? Does that meet the requirement of Trivandrum, at least one district in Kerala? No, absolutely not. So how do we achieve that kind of result? How do we ensure that palliative care reaches every single person who requires that support? There's only one way out. You work with other organizations, other entities, and that is easier said than done. It comes with its own set of challenges. Like here, each of these links that we have that I have shown here, it could be a government medical college, it could be a private hospital, it could be a community-based organization like we discussed earlier, it could be a primary health center. Now, once you have these links established and you work with them, see the number of the increase in the number of patients that we could take care of. Your capability to deliver care, it grows multifold. Now, this is what we still believe in. We still work with other entities. Like I mentioned, even the government, we work with private entities, we work with hospitals, and we also work with, okay, 5 more minutes. Yes, we'll try to. So we work with a lot of these, another point. Okay, thank you. I was just reading through the message on the chat box. Sorry about that. So each of these links, each of these relationships, it takes time and effort to nurture that, to make it fully effective. But then that is something which you have to keep doing. And it's not just within the state. We do it even outside the country. We work with a lot of other governments. We work with other institutions in different parts of the country. So I think this, and we just share one more story probably. I'll just try to finish it in 5 minutes. So Sita is actually a palliative care patient. She underwent a spine surgery, and then she had problems with that, and then she became a palliative care patient. Someone in her area again connected her to Palliative India. We provided the initial care, took care of her basic, addressed the basic needs, including some physiotherapy and all those things. And then she's paralyzed, she's wheelchair bound, but today she makes jewelry and sells it online. And she is the only earning member of a family, which includes her parents. Now, how did that happen? How did, from being a palliative care patient who is practically almost bedbound, I would say, to the transformation to being the earning member of the only earning member, the breadwinner for a family. Now, this did not happen overnight. It took years. Like, for example, once the initial symptoms were managed, basic physiotherapy and all those things were provided, she was also provided a wheelchair, but then that was not enough for her. Obviously, you need to survive. How do you survive without income? So someone came up with a suggestion. One of the volunteers came up with a suggestion that we could teach her how to make jewelry. Okay, so she was taught how to make jewelry, and she started making jewelry using those tips. But then comes the next challenge. Making jewelry is fine, but ultimately it has to convert into money, right? So you need to sell it. How do you sell it? A patient on a wheelchair, can she go out to the market and sell this wares and make money out of it? No, practically not possible. Then came the next big idea. Someone suggested, okay, why don't you sell this over the net? Today that is happening a lot. You can use the medium, the internet to sell us a lot of these kind of stuff. Idea was fine again, but then you need a computer and an internet connection at least. And Sita was not even, she didn't even know how to operate a computer, let alone have a computer. So again, some of our volunteers came together, taught her how to use computer, and then we put out an advertisement in our website, and we spread the word around saying that such a person requires a computer, and for this purpose. And there were other good-hearted people who came along. Someone from some part of the country came forward and said, okay, I'll donate the laptop. And then local service provider came up, the internet service provider said, okay, we'll offer the internet connection. Now, once these things were there, she was able to start selling using Facebook. That is the medium she uses. She's on Facebook, and even today she sells it online. Now that, again, the story did not stop there. There was no motorable road to her house, and the local the neighbors got together, made sure that there was sufficient width for the access so that at least a vehicle can pass through. The panchayat came in, stepped in. They made sure that there was at least a kacha road set up so that the vehicle access is easier. Now, all these things came together for Sita to transform from a palliative care patient to a contributing member of the society, where she can earn something, she can take care of her family, and her dignity is restored, at least to a large extent. Now, this is what is required if you really need to achieve big results. That is where collaboration comes in. Now, this example, what I just mentioned, it's an example of collaboration between multiple entities. The government machinery was involved, at least the panchayat was involved, the neighbors were involved, an NGO, Palliative India, was involved. There were volunteers who were involved. So when everyone comes together and tries to solve a problem, common problem, put in their own ideas, then you have bigger productivity and innovation happening. And let us also not forget that we are all human beings with our own set of what you call the 7 deadly sins, as they call it. We come as a package. We cannot imagine that we are all selfless people out there to support the community and help people. No, we have our own self-interest, and that is something which we have to recognize even when we work with other individuals and entities. So we'll have our own reasons for doing something. The other entity also, they'll have their own reasons for doing something. And you also need some kind of leadership, without which nothing is going to change, nothing is going to move forward. Just set of people coming together is all fine. 10 people coming together, good interest, that's fine. But then you also need leaders. And unless there is this leadership in that group, it still doesn't translate into a proper collaboration. So it starts with me. And it starts with the process of inquiry. It's the questions that we ask ourselves. Like probably Ken Nair asked himself, why, what, how? And the why, I believe, is more important than all the other questions. Once we are clear about why we want this to happen, why we want to do this, innovation happens. I can give you hundreds of examples of innovations that have happened in Kerala, but this example of what do you call community-based care is a brilliant innovation. it inspires people. The message spreads. More people get to know about it. More people want to do more. Now it spreads, and it has got a much larger impact. And it's kind of that ripple effect that you drop that one stone, and it then grows into a bigger ripple. Like it goes from the individual to the community, and it has the power to transform society. Okay, so and all this has to start with that I. And if you just wait for the government or others to step in and make sure that all the conditions are available to provide palliative care, nothing is going to happen. So each one of us will have to decide to do our bit, take that first step, and that is when this change will start happening. So the key, as we understand, for good collaborative working is something which I think you have already had your communication classes. So it's about understanding each of the other partners in that collaboration. If it is a CDO, we need to understand what they are looking for. What is it that they are able to offer? If it is a government institution, we should know what their requirements are. What is it that they want to achieve? And once we understand each other as partners, and we know the common goal, which is to provide the care to the patient and family, we will be able to achieve much bigger results. And how do we know what the other partner wants? It's very plain, simple. There is only one way you can know what the other person wants, and that's to listen. You listen carefully, the other person will come out and say what the other person. Collaboration with beauty, college beauty parlor youth group for a business. Yeah, why not? That's a good idea. Why not? So I leave you with this thought, or thought in the sense you can contribute. My question is, who is the most critical member of this team now? You said we need a team. My question is, who is the most critical member of the team which is supposed to provide palliative care?
Mr. Binod, every passionate team member is a critical member of the team. As an ambulance driver is important, and the surgeon is also important. Obviously, a delivery boy of a milk who delivers milk is delivered at the doorstep every morning. He keeps our life comfortable. A paper boy who delivers the paper, he keeps our life comfortable. So every one of us can definitely contribute. But what I would like to say, small example here. It is like carrying a 10-kilo weight for 10 kilometers. When I'm sick, it is very, very difficult to do it. The community can come forward, break those weights into smaller weights. It could be 500 grams, 1,000 grams, 2 kilos, 3 kilos. We can share that, and we can travel together for 10 kilometers. It is how I'm going to affect the journey and make it more comfortable, rather than looking into the certainty of life when it strikes. It is not important. But the journey, if we are able to do it together, it is more enjoyable.
Yes,
thank you.
Absolutely. Absolutely. Thank you. Any other thoughts?
Excuse me, sir. I would like to interfere in between. So actually, we have a case presentation too. So
4:30, right?
Yeah, sir. So can we come back to this question after the case presentation? Is it okay, sir?
No, we're just closing it. This is the last slide. So I'm just going to leave it here.
Okay,
4:30 you mentioned, right? We still have 5 more minutes, I guess. What's the time now?
No, sir. It's already 4:20. So the case was supposed to be taken by 4:05 actually, sir.
Oh, sorry. I didn't know that. Sorry. So sorry. So then, I think we'll conclude here. So this, I thought it was 4:30. It's my mistake. I apologize. So each one of us is critical to this team, as Ramakrishna mentioned. the one who conceptualizes and is able to involve others, yes, but each one of us, we are all critical team members. Let us not forget that. And sorry for the delay. I thought it was up to 4:30. Over to you, Gayatri. Thank you. Thank you very much.
Thank you, sir. Thank you so much. So it was a very
Thanks, everyone.
It was a very clear and detailed session. Thank you, sir. Thank you so much. So we can directly move on to the case presentation. We have a case presenter here, Ms. Sinthu Ishwaran, who is a social worker by profession, and she is also one of the very vibrant participants of FCPC. So I would like to invite you, ma'am. So we'll be sharing the slides from our side.
Okay.
Okay, ma'am. Okay, ma'am. Over to you.
Hi, everyone. I think I'm going to be slightly rushed because I have to get somewhere, but so the presentation, I can't see it. Yes. Yes, so this is, I don't know how to, one of the beneficiaries that I'm in touch with, Mr. B, who is about 65 years old, and he's been diagnosed with COPD and he's paraplegic. And his background, and he's on a wheelchair at the moment, and he used to be like a factory worker and held various other odd jobs. And his history is the place where he lives is not very good hygienically, and he's suffered from severe bed sores. And because of his paraplegia, he's always in pain. I mean, every minute there's just the scale goes up and down. And he's a smoker, and the COPD, just aggravates his breathlessness at times. He's away from his family, and I'm just going skipping a few things. He's very much aware of his condition. He knows that's where he's at, but there are times when he just is so motivated to think he'll walk again, which is very heartwarming. But his family, they live far away. He lives in a care home, also financially not very good, so they can't really visit him. So he's sort of disconnected in that sense. And I say he's aware of palliative care because he's been to the rock bottom in his life. So he knows anything he receives now, he receives it as a gift. So so in that sense, he might not know what is palliative care, but he understands any care he receives at this moment. He's very grateful for that. Just quickly, he has 4 children. One of them died. Daughter is a widow, and 2 other sons. The children and the wife, they live very far away, like about 150 kilometers. And they are from the mountain villages here in Uttarakhand. So it's all the more difficult to get for them for road access and things. I think just to have a discussion or just an idea, I find that the old care home where he lives in, he's like the sole verbal resident, and everyone else around him are either autistic or they can't speak or they can't hear. And he's the sole verbal resident who can operate a phone. And there is a caretaker who's also sort of a part-time labor. So he goes away when he gets a job, but he's always cooking for them. So there's not really somebody who's a sharp-minded, who knows what to do, who to call. And maybe we just go to the eco map. So it's, So his point of contact is really us, like a friend and I, and we live quite far away as well, but we are his contact. And there's one very sweet neighbor who sometimes visits and say hello, and who's in connect. Family is far away physically, and the closest government hospital, honestly, is almost like very defunct in some way. Like once when he went there for severe pain, they just sent him with a paracetamol. So almost not ready to listen or what this person needs, not even wanting to look at his case. And other neighbors around the care home, not so interested about what goes on in this community. Okay. What then? Yeah, he's since he's held various jobs, and before he had some education as well, so he knows his he has access to his disability pension, but of course someone needs to take him if he needs to access this money. And yeah, generally, like I said, very positive person. Sorry, I'm rushing. And yeah, the total pain. Yeah, so there was one doctor that we could, one hospital that we could sometimes bring him to when it was in extreme pain. And that doctor last year died of COVID. So that connect with this doctor, he still mourns that, his psychological, so he feels very abandoned in a way. Physically, like I said, he's always in pain, and positive person, but at times when he phones, he's like, oh, when is this going to end for me? Why has this happened to me? So, but very balanced, somehow comes to the acceptance that that's his life, that's his destiny. So I thought it's really interesting for me also, like interesting to learn for me how to respond to somebody like this who lives in a community, probably the most intelligent person in that community, with articulate verbal skills, but lives so far away, remote, and just how to mobilize people around, how to motivate people around to take the slightest interest, maybe if there's some call in the night. That's what I was really looking forward to from all your experiences, and how can one motivate close neighbors to take an interest in for this community. Yeah, that's it.
Thank you, Sindhu ma'am. Thank you so much. It was very clear. So these are the questions came as discussion points. Now the floor is open for all. Kindly give your suggestions in the chat box, or else you can unmute yourselves and speak.
This is Dr. Hema Biju. I'm an occupational therapist. I have a question for Sindhu. Is this person, he is a paraplegic and he has a COPD, but is he in a palliative care center, or just because he's a paraplegic and a COPD patient, does that mean that he is in palliative care?
No, what I meant was, no, he's not in like a palliative care center. He lives like in the old care home, but he's somebody who
palliative patient, right? He is a patient. He's a disabled patient who needs rehabilitation, but not palliative care.
But this chronic pain and this very severe COPD, that not a...
Yes, so maybe he needs pain management. But would I call it palliative care is my question.
But it still relates in some, chronic pain that just increases every day. So pain management is, would you think that's not part of this, or community engagement? Or maybe I got it wrong.
No, it is. So basically he needs to be rehabilitated, right?
I'm not sure what you mean by that.
I deal with a lot of paraplegic patients the whole day, and we have patients from kids to elderly, and we try to rehabilitate them and try to increase their functional independence and quality of life, right? So this also seems like a case like that, but my only question was that because he is paraplegic doesn't mean that we have to help him for end of life
Maybe I misunderstood that. It's not, I don't literally mean end of life, but even this rehabilitation.
So,
To get the
to answer your questions, that is how to mobilize community support. So he is paraplegic, and he is on the wheelchair, and he's the verbal person for that community, but his hands are good, right? He's a paraplegic, so with his hands, and he has worked with odd jobs. I'm sure there are things that he could actually be able to do to not only provide help to his other people who stay with him, but actually earn something for himself and his family.
Right. I think I was thinking more. Sorry, go ahead.
No, Sindhu ma'am, you please carry on, please.
No, I think my intention was, it's also, the place where this whole setting is. It's from a very poor community. So there's not really any interest or, I just go there because I know them, sort of thing. It's not, there's no really interest to think of anything for this space. So I understand the sort of like a business to get them to do something, but really what this whole space or he really needs is an emergency involvement from the community, which has already happened 4 or 5 times, and it's always me or someone else rushing from 35 kilometers far. And just to get a little more interest in, so I was more interested in how can one get a bit more interest from the community for this place. Anything would be great.
Is he interested in gardening, or maybe basketry or things like that, and basketry, or where he can, while sitting on his wheelchair, he can do these things and selling it to the community nearby, and getting them to initially interact, and then the possibilities open up, and slowly once these possibilities open up, they can see what is the need of that community and be able to support each other, not just the community supporting him, but he can also support the community. So
okay,
yep.
Both
Or
your
the others
points
for other ideas.
Yeah. Yes, ma'am, both your points are absolutely right. But in this case, I think before rehabilitation, what we have to do is we have to shift this man to any other centers with better quality, better facilities. Like here, he's having severe pain, then chronic pain. Yeah, like Sindhu ma'am mentioned, chronic pain, then bed sores, everything is there. So before enhancing the patients daily activities or like their functioning, we have to focus on their physical pain because he is having bed sore and all, no. So both of
Yes.
your viewpoints are right. But somehow
Also,
yeah.
if I can make a point after this, after you.
No, you please proceed, ma'am, you please proceed.
Okay. So see, as an occupational therapist, I have realized that these paraplegic patients, they have this chronic pain, which is actually paresthesia or different kinds of pain. This could also come through because of these severe bed sores that he has, and which need to be taken care of. So he needs initially, yes, he needs proper treatment, or at least exercises to show him how to move, continuously move, and help in the healing of bed sores. Once the bed sores are taken care of, his paresthesia might reduce, so that can take care of his chronic pain. Okay. And like I agree with her when she says that he needs to go to a better facility where he may have a chance for treatment. So if that is a possibility, yes, first that should be the first thing to be done. Thank you.
Thank you, ma'am. So regarding the community mobilization, comments are coming in the chat box, like we can create and motivate and educate a student group for helping him. Yeah, it's right. Pain managed by both approach, rehab and palliative. Uh, Parag sir, can you make an explanation for your point?
I just want to say like that the pain manage can be with both the approach, rehab and the palliative. Only the decision of the stages when to start with the rehab and when we have to start with the palliative, it may be differ from the every expertise. So it may be the both approaches are very good at the time of the pain management, but the decision making it in terms of the patient aspects, we need to see the overall aspect of the patients, and then only we need to decide what kind of the approach will be best suitable for the as per the rehab point of view or into the palliative. Sometimes both the approaches goes hand in hand, so we should not. It may be the overlap or it may be go hand in hand, and sometimes it is misunderstood by the every expert. Yeah, so it is depend on the how we are going to take that. So it is a we are a multidisciplinary team members, everyone has their own aspect to see the patients. So I think Hema ma'am also is right, even the Sindhu ma'am is also maybe right on the that their aspects to do give them the to see the pain aspect of the patient. That's what I want to clarify. That's all, thank you.
Absolutely, sir. Thank you so much for that valuable point.
Yeah, I mean, we have like a system where, you know, once in 10 days, somebody goes and delivers medicines or something. But it's just the difficulty is getting anybody around to even check or say, if you need, can we get you your medicine? And things are so far away, up and down in the roads in the mountains, that the ease of access is, so it's somebody needs to go there. That's, so I was wondering, I was wondering, has anybody had an experience in motivating neighbors? That first question scenario that we had, that reaching out, like go and knock. Has anybody had an experience in how to motivate someone to just say, hello, you can call me or something, just, or they, something like that?
Is there any attempt made to use the technology like video calling or calling through phones?
Well, like he operates this small phone, which is the only sort of lifeline, I mean, you know, phone line connection that we have. But again, it's also financially to see, that was another thing, like he's not in a position to have to afford something.
Sindhu, a suggestion, maybe like when you all go to meet them, maybe you can ask the neighbors if somebody has online connection or something, if they can show this patient once in a week or twice in a week, whatever is possible for them. If they can show him some rehab online session or something, meaning at first we have to get a therapist to probably work with him for some weight relieving techniques and all, and if a neighbor can show it to him on his mobile, so that you know he can do something, and that way the neighbor will also be involved, as well as his therapy will therapy and pain management and bed sore management will be achieved. So that way we can achieve both the goals, you know.
Yeah,
so
I'll try that.
like you said, like somebody said that somebody has to have the courage first to approach somebody for help. So that courage, if so that once a
we've
person
tried
knows
that.
how he can help, they
Okay, I'll try that again. We have tried that, and of course when we go they say yes, but it's not always the case.
Yeah,
yes,
one more thing.
so
What
you know
about
what,
his
if you want a
smoking
therapist,
status now? Sorry.
if you want a therapist, maybe I can volunteer for pressure relief, and once you tell them that this doctor is involved in him and she will call once a week or twice a week, then maybe they might, you know,
right,
if they have something definite structured, then they are willing to help kinds.
Right, okay, good idea, we'll think about it. Thanks.
Yes,
Yeah.
thank you.
Yeah, my concern was, what about his smoking condition now? He's quit or he's still smoking?
No, he hasn't quit. He is very much continuing and just laughs when says, what to do, and then it just says he's going to quit, but no. So it's,
Okay.
yeah, no, he maybe for an hour or something when we are there, we take it away. But of course, it's on when we leave. So
Oh, yeah.
it's small. It's like a small. It's sometimes it's also like can't control it from so far away, and in the end of the, like I said, he's hit rock bottom so much in his life that his view is anyway it's going to happen. So he has that, in that way, that strength of looking at his life is there. But it's this pain, this chronic pain, or that immediate help is what is needed for this person. But yes, okay, I'll try the different things that everybody has suggested.
Yeah, the pain may be due to the smoking, because most of the time these bed sores or the wounds that smoking itself will add up more pain. Maybe try for counseling to quit the smoking.
Yeah.
Yeah. Okay, thank you.
Thank you.
Thank you all for your comments. Binod sir, do you have anything else to add?
Sorry. No, nothing else. I'm so sorry once again. I thought it was still 4:30. So I think we finished the session. Is there any questions which, so if someone has any questions, if you want me to clarify something, I can do that, or it could be later over the email or whatever. That's also possible.
Okay. Is there any questions left? Okay, thank you, sir. Thank you so much for your wonderful session. It was very clear and interactive, as I already mentioned. Thank you so much, sir. And Sindhu ma'am, thank you. Thanks a lot. And let's see you on next Wednesday. So we have shared the feedback link here. You can fill it up, and we'll be also sharing it in the WhatsApp, and you can also use that link. Thank you. Thank you so much.
Thank you.
Thank you. Bye.